Good afternoon. My name is Ann Kimball. I'm going to be talking about trends in congenital syphilis-related deaths in the United States from 2013 to 2018. Congenital syphilis is an infection with the bacterium Treponema pallidum in an infant or fetus that is acquired during pregnancy from a mother with untreated or inadequately treated syphilis. The bacteria in the maternal bloodstream crosses the placenta and infects the fetus. Placentas show signs of infection and inflammation. This placental inflammation can cause miscarriage, stillbirth, or preterm delivery. Complications of the infection and of preterm delivery in the infant can lead to early infant death. Infants with congenital syphilis who survive can experience lifelong physical and neurologic problems due to chronic inflammation and scarring. We know that the timely identification and adequate treatment of maternal syphilis can prevent congenital infections and the associated morbidity and mortality. Adequate maternal treatment of syphilis is defined as completion of a penicillin-based regimen that is appropriate for the maternal stage of syphilis and initiated 30 days or more before delivery. Thus, identification of maternal syphilis must occur 30 days or more before delivery in order to prevent congenital syphilis. The number of CS cases in the US continues to increase. In fact, the number of cases increased 261% from 2013 to 2018. In 2018, 1,306 cases of congenital syphilis were reported to the CDC, which was the highest number of cases since 1995. Preliminary reports from 2019 show continued increases, with over 1,600 cases reported to CDC by July of 2020. Our objective for this analysis was to describe recent trends in CS-related deaths, which are the most serious outcomes of CS, and identify opportunities for prevention. CS is a nationally notifiable disease, and case reports are submitted to CDC from all 50 states and the District of Columbia. According to the CS case definition, the surveillance case definition, cases reported to CDC include stillbirths and infants born to mothers with untreated or inadequately treated syphilis, regardless of signs in the infant, or infants with clinical evidence of congenital syphilis. This includes direct detection of Treponema pallidum or an infant with a reactive non-treponemal syphilis test who has signs on physical exam, radiographs, or cerebrospinal fluid analysis. For our analysis, we included CS-related deaths from 2013 to 2018. This includes stillbirths, defined as fetal deaths after 20 weeks gestation to mothers with untreated or inadequately treated syphilis, and early infant deaths. For infants who meet the surveillance case definition, were born alive and then died. We calculated the percentage changes in the numbers of CS-related deaths from 2013 to 2018. We also calculated annual case fatality rates using CS-related deaths divided by the total number of cases reported to CDC for that birth year, or those with known vital status. Additionally, we stratified by maternal race ethnicity to evaluate for possible disparities. Finally, we reviewed gestational age at delivery and estimated maternal receipt of timely prenatal care. Timely prenatal care is defined as receipt of any prenatal care 30 days or more before delivery, as we know that CS prevention relies on treatment of maternal infection within this time frame. We found that CS-related deaths increased 236% from 2013 to 2018. The highest burden of CS-related deaths during this time period was among non-Hispanic Black mothers, which comprised 38% of all CS-related deaths. For the rest of this presentation, when we talk about disparities, we will focus on non-Hispanic Black mothers, Hispanic mothers, and non-Hispanic white mothers. CS-related deaths increased 282% among Black mothers. CS-related deaths increased 100% among Hispanic mothers. And finally, CS-related deaths increased 360% among non-Hispanic white mothers. This graph shows all three put together. And we can see that while the highest burden is among non-Hispanic Black mothers, the percent change was the greatest among non-Hispanic white mothers during this time period. The annual case fatality rate has been relatively stable from 2013 to 2018, with an average of 7.7%, depicted by the dotted line. The average annual case fatality rate was highest among Hispanic mothers at over 9% and lowest among non-Hispanic Black mothers. Changes in the annual case fatality rates over time did vary by maternal race ethnicity. You can see here that the case fatality rate among Hispanic mothers appears to decrease over time, while the case fatality rate among Black and white mothers appears to increase slightly. The mean gestational age at delivery for CS-related deaths was about 30 weeks, with little variation by race ethnicity. This figure shows the gray line, which is the average among all race ethnicities, with the bars showing mean gestational age by race ethnicity. 66% of mothers whose pregnancies resulted in CS-related deaths did not receive prenatal care 30 days or more before delivery, and this did vary by race ethnicity. Again, the gray line shows the average among all race ethnicities, and you can see that the proportion of mothers who did not receive prenatal care is higher among Black and Hispanic mothers than it is among white mothers. Few of the limitations for this analysis. Case report data provides limited information about maternal socioeconomic status, as well as the infant's clinical picture. So we cannot explore additional maternal risk factors for adverse pregnancy outcomes, and we also can't explore additional clinical information that may help us understand why these infants or fetuses died. Additionally, reporting of syphilitic stillbirths and early infant deaths may not be consistent across jurisdictions or over time. First off, CDC does not provide concrete definitions for early infant deaths. And secondly, while maternal syphilis testing is indicated during prenatal care for all pregnancies, as well as after delivery of stillbirth, about a third of women who deliver stillbirths do not receive syphilis testing. And this is based on an analysis that was performed using data from 2013. In conclusion, the number of CS-related deaths has risen drastically in the United States since 2013. The largest relative increase was among white mothers, but the highest burden was among Black mothers. In order to prevent congenital syphilis, maternal syphilis must be identified and treated 30 days or more before delivery. As the average gestational age at delivery of an infant or fetus with a CS-related death is about 30 weeks, identification and treatment of maternal syphilis must occur early in pregnancy in order to prevent fatal outcomes in most cases. Thus, syphilis screening in the third trimester, which starts around 28 weeks, is likely too late to prevent congenital syphilis-related deaths. The majority of mothers whose pregnancies resulted in CS-related deaths from 2013 to 2018 did not receive prenatal care 30 days or more before delivery. Unfortunately, Black mothers had the lowest rates of prenatal care. In conclusion, access to early prenatal care and universal syphilis screening for all pregnant people at the first prenatal care visit is critical to prevent congenital syphilis and CS-related deaths. Thank you.
Welcome. This presentation is titled Syphilis Reinfections During the Same Pregnancy, Florida 2018. I'm James Mathias. Congenital syphilis is increasing in both Florida and the United States. From 2009 to 2018, in Florida, congenital syphilis has increased over 400%, from 21 infections in 2009 to over 100 infections in 2018. Likewise, congenital syphilis has increased over 200% in the United States, from over 400 infections in 2009 to over 1,300 infections in 2018. Similarly, primary and secondary syphilis among women has also been increasing in Florida and the United States, however, at not nearly the same magnitude. Only 142% increase in Florida and 124% increase in the United States. In Florida, the key to preventing congenital syphilis and in the United States is screening in the first trimester, the third trimester, and delivery. These are required by law in Florida. The other key is timely treatment. However, with timely treatment, that does allow for the risk for reinfection to occur. 3 previous studies have identified that 8 to 22% of congenital syphilis infections were due to reinfections. However, 2 of these studies had denominators of their mothers to calculate the percentage of pregnancies resulting from reinfection. And they have found that between 1.8 and 2.6% of their mothers became reinfected during the same pregnancy. And these studies were done in New York City, and one was done in Florida and Louisiana in 2013 and 2014. So what we wanted to do was examine syphilis case reports among pregnant women in Florida from 2018 to determine how often these reinfections occurred, the nature of these reinfections, if these infections occurred among a subset of women or all women, and whether or not these reinfections resulted in congenital syphilis. So what we did is we took reported pregnant females with syphilis diagnosed between January of 2018 through December 31st of 2018. We organized these women by pregnancy for each of these women so that each woman only had 1 pregnancy counted, and calculated total number of unique pregnancies, and then linked each field record within a pregnancy so that only each pregnancy was counted once. So then we followed these pregnancies from their last menstrual period, all of their labs, case records, and other data associated with each pregnancy across the course of their pregnancy from their last menstrual period through their delivery. And we used the CST case definition as our way of determining whether or not they were reinfected or whether or not they only had 1 infection during their pregnancy. We then determined if each mother was susceptible to reinfections, whether or not they received appropriate treatment for their stage of syphilis, started greater than 30 days prior to delivery, or whether or not they were just identified at delivery. And then if mothers were determined to have been reinfected using the CST case definition after receiving appropriate treatment for stage of delivery. And we excluded pregnant women that were not susceptible to reinfection, those that did not receive appropriate treatment for stage of delivery, or those that were not identified greater than 30 days prior to delivery. And then we compared the demographic characteristics of women that were reinfected versus those that were not reinfected but susceptible to reinfection. And pregnant women with reinfections were further described by the stage of syphilis at diagnoses, their non-treponemal test titer value changes, their treatment history, their variation in testing location, and congenital syphilis outcomes. In total, 369 pregnant women with syphilis were identified in 2018. 261 of these women were at risk for syphilis reinfection as part of our study population, and 108, or nearly 30% of our women, were excluded. The reasons for their exclusion included those that were diagnosed at delivery, 57, insufficient treatment greater than 30 days prior to delivery, diagnosis less than 30 days prior to delivery, miscarriage of their pregnancy, termination of their pregnancy, or loss to follow-up. In total, of our 261 women that were susceptible to reinfection, a grand total of 19, or 7.3% of our women, went on to be reinfected. 242 of our women, or 93%, were not reinfected. All 19 of our reinfected women, or their second reinfections, were staged as early non-primary, non-secondary infections based on serological diagnosis. 17 of the 19 women had a 4-fold titer increase between the first and second reinfection, while the remaining 2 had a 2-fold titer decline. So that means that they had what we would call a appropriate titer decline between the first and second decline, adequate to their 4-fold titer response, or appropriate treatment therapy. And then had a subsequent 4-fold titer increase or more after that 4-fold titer decline from their treatment. All 19 mothers were HIV negative for reinfections, and only 1 mother reported drug use during their pregnancy. 8 of the 19 mothers, or 42%, reported an 8-fold or higher increase upon their second diagnosis. The remaining 11 had only a 4-fold titer increase. But I do want to focus on these other 11 mothers further, because 9 of these 11 mothers had additional testing and treatment following their second infection, Only one was not retested following their second diagnosis, which means that 9 more were tested again. If we look at these 9 more individuals that were further tested following their second treatment for their second infection, 3 more had an increase upon testing in their titer upon retesting, which means they also had an 8-fold or higher test increase in their diagnosis, which is strong evidence for reinfection. 4 more had a stable 4-fold titer increase upon retesting, which clearly means they met the surveillance case definition. And 2 had a decrease in titer upon their retesting over 2 months post-treatment in response, and this could be a response to their actual therapy because they were retreated after their testing. Now, if we look at their test timing, 7 reinfections occurred greater than 30 days before delivery. And this is when they were retested either in the second trimester or in the 28 to 32 week period following the third trimester. One of these mothers was treated and reinfected a third time by delivery by the surveillance case definition, and therefore was not prevented from meeting the surveillance case definition for congenital syphilis. However, 6 reinfections were treated and congenital syphilis was prevented. Therefore, we were able to prevent 32 congenital of these cases were prevented from becoming congenital syphilis. However, 13 reinfections in these mothers' cases ended up meeting the congenital syphilis case definition, as 12 of these mothers were tested at or less than 30 days before delivery. And again, 1 mother from above was treated and reinfected again at delivery. So in conclusion, reinfections were common, and we did identify the risk, which was 3 to 4 times higher than the previous studies at 7.3% in our study compared to 1.8 or 2.6% from previous studies. This could be due to the higher prevalence of female syphilis now compared to 2013 and 2014 when these studies were done before, or this could be due to partially to the exclusion criteria where we removed mothers in our study who were not susceptible to reinfection. What we also found is that some women and their partners may benefit from active case management throughout the course of their pregnancy. We did find that there were continuing challenges with identifying congenital syphilis case management. As all of these reinfections were diagnosed by increases in non-treponemal test titers, some of this may be difficulty in determining reinfection versus titer and clinical case management of patients and so forth. Again, nearly 30% of our maternal syphilis infections were excluded because they were not treated greater than 30 days before delivery, and late detection and treatment remain a significant cause of congenital syphilis in our female syphilis population. Yet we have continuing optimism in this population. Third trimester screening still identified and prevented nearly 30% of those that were reinfected in our population. And this study highlights a truly at-risk group for OBGYNs to focus efforts and ensure third trimester screening and delivery for testing. And finally, this reiterates the need for partner services among sex partners for those women, and these women remain at risk throughout the course of their pregnancy. I'd like to thank my colleagues at the Florida Department of Health, and all of the DIS, case reviewers, and UNI staff involved in investigating pregnant women within the syphilis in Florida. And I'd finally like to thank my colleagues at the CDC for help with their project. Again, thank you very much.
Hello, my name is Anna Berescolms. I'm an epidemiologist with the Public Health and Seattle King County Sexual Health Clinic. I would like to start by thanking the conference organizers for this invitation to present and my co-authors for their contributions. My talk today will be about the rising rates of syphilis among cisgender women and risk factors associated with pregnancy at diagnosis in King County, Washington from 2008 to 2019. The most recent syphilis data from the CDC shows syphilis rates increasing among women in the United States. In this figure, the line is for the primary and secondary cases or rate among women, and the congenital case count are in the light blue bars. As seen in this figure, primary and secondary syphilis rates among women ages 15 to 44 have been increasing since 2013. The number of congenital syphilis cases has followed the same pattern. Although lower rates than those seen nationally, increasing syphilis rates have also been observed among King County women. The figure shows that the rate of syphilis of all stages has increased from 2008 to 2019, driven by increases in both early and late syphilis, with recent increases in early stages of syphilis. The top line is the overall syphilis incidence rate among women. Below that is late syphilis, and in the lightest blue, early syphilis. In 2019, 3 congenital syphilis cases were reported in King County, the first since 2015. For these reasons, we sought to characterize King County women diagnosed with syphilis by pregnancy status. The specific aims of this project were to first better describe and understand the trends in syphilis among King County women from 2008 to 2019. Our objective was to identify key populations that may be potential drivers of the observed increases. The second aim was to identify risk factors for syphilis during pregnancy. In order to complete these objectives, we used county surveillance data to calculate syphilis incidence from 2008 through 2019. This analysis included all stages of syphilis and was limited to cisgender women. We examined trends in incidence by race, ethnicity, age, and pregnancy status. Additionally, we evaluated associations between pregnancy at syphilis diagnosis and potential risk factors. This part of the analysis only included cases with a known pregnancy status who were interviewed for partner services and was limited to cases diagnosed in 2014 to 2019. Prior to this, pregnancy status was not on our STD case report form, and many cases were missing pregnancy status information. The risk factors we examined were race, ethnicity, age, injection drug use, methamphetamine use, or exchange sex in the past year. We used Fisher's exact test to analyze for associations between these risk factors and pregnancy status. Additionally, although we wanted to include housing status as a risk factor, it was not a field available for analysis during this time period. We are now moving to the results of the first aim of the study, which was characterizing the changes in syphilis trends among women from 2008 to 2019. In this figure, the orange line indicates the rate, and the cases are shown in the blue bars. From 2008 to 2019, syphilis incidence among women increased from 3 cases per 100,000 to 7.7 cases per 100,000, which represents a 2.6-fold increase. This corresponds to an increase in syphilis cases from 28 reported in 2008 to 86 reported in 2019. There were health disparities in syphilis incidence by race ethnicity in King County. Black women, shown in the blue line, experienced the highest rates across this whole time period, with a large increase in incidence starting in 2014. Latina women, represented by the green line, experienced recent increases, especially compared to the rates among Asian Pacific Islander women and white women. While Black women experienced the highest rates, Latina women had a 4.1-fold increase in incidence, which was the greatest increase in incidence over the time period. In comparison, there was a 2.7-fold increase among white women and a 2.1-fold increase among Black women. Women ages 20 to 24 had the largest increase in syphilis incidence from 2008 to 2019. In this figure, this age group is indicated by the orange line. Women ages 20 to 24 went from the age group with the lowest rate among women in 2008 to the highest in 2019, experienced a 16.8-fold increase in incidence. This age group also accounted for an increasing proportion of syphilis cases among women, from 4% in 2008 to 21% in 2019. In 2019, the 25 to 29-year age group had the second highest rate among women, followed very closely by the 30 to 34-year age group. Now we move into the results of the second aim of the study, which was to identify risk factors for syphilis during pregnancy. 348 cases of syphilis among women were diagnosed from 2014 to 2019. Of these, 106 or 31%, were interviewed for partner services and had a known pregnancy status. These 106 cases were included in the comparisons of pregnancy at syphilis diagnosis and potential risk factors. 30 cases, or 28% of these, were pregnant at diagnosis. King County disease intervention specialists attempt to contact all women diagnosed with syphilis in our jurisdiction to offer partner services. However, we face many difficulties in interviewing with women with syphilis in our local health jurisdiction. Women are often not located, 44% of those not interviewed, or if located, refuse an interview, 7% of those. We found no significant associations between race, ethnicity, age, injection drug use, methamphetamine use, and exchange sex and pregnancy at syphilis diagnosis. Although not significant, we still had informative key findings. Asian and Pacific Islander women and Black women had the highest proportion of cases pregnant at syphilis diagnosis, with 44% and 35% of cases, respectively. By age, women 30 to 34 years with 50% of cases pregnant at diagnosis had the highest proportion of pregnant cases. Injection drug use, reported by 8%, methamphetamine use, reported by 11%, and exchange sex, reported by 4%, were frequently reported among all interviewed women. In conclusion, syphilis in King County disproportionately affects women of reproductive age and women of color, threatening women's health and that of their children. These analyses have some important limitations which affect the generalizability of these findings. 58% of women were not interviewed for partner services, and 51% were missing pregnancy status, limiting our ability to fully understand observed increases in syphilis incidence. And the cases included in our study may not be representative of all syphilis cases among King County women. Small sample sizes and missing responses to risk factor questions may have limited our ability to find statistically significant results. These results highlight the need for innovative ways to reach this population for effective public health interventions to control and prevent syphilis in women and their children. Identifying women at risk of syphilis during pregnancy is vital for the prevention of congenital syphilis. Improved data collection is only possible if we can engage women diagnosed with syphilis with public health. And as mentioned previously, our jurisdiction has faced difficulties in locating and interviewing these women. We have recently worked to create new relationships and improve communication with our county jail services and local providers to assist in treating and locating cases in need of an interview. However, there is much work to be done so we can gain a deeper understanding of the increases in syphilis incidence among women and can truly disrupt this epidemic and begin to dismantle these health disparities. This concludes my presentation for today. Thank you to the conference organizers, co-authors, and the hardworking King County disease intervention specialists.
Hi, everyone, and welcome. My name is Fonta Drame. I'm a CDC Public Health Associate assigned to the New York State Department of Health, Office of Sexual Health and Epidemiology. Although they are not here presenting with me, I would like to introduce my colleagues from the Department of Health, Srikanth Boma, Wilson Miranda, and Dr. Rachel Malloy. Today, we'll be looking at the evaluation of drug use-related behaviors among females diagnosed with early syphilis in New York State outside of New York City from 2013 to 2018. Please note that the findings and conclusions of this evaluation do not represent the official position of the CDC. So the presentation today will be broken down into 4 sections. The first section is the background, where we'll highlight why this evaluation is important. We'll go over key terms, syphilis trends in New York State, and also take a look at a national study which prompted this evaluation. A few of the key terms that will be used throughout this presentation are the following. So we have drug use-related behaviors, also referred to as DUBs. They are inclusive of the 4 behaviors: heroin use, injection drug use, sex with a person who injects drugs, and transactional sex for drugs and or money. Females are individuals who self-identify their sex as females. And New York State is the entire state apart from New York City. And then we have early syphilis. So syphilis is a sexually transmitted infection that can be described in terms of its 4 stages. Early syphilis is inclusive of the primary, secondary, and early non-primary secondary stages of syphilis. So early syphilis diagnoses continue to increase in New York State. 2019 marked the 10th consecutive year of increases. From 2018 to 2019, there was about 30% increase in diagnoses. Although diagnoses are highly prevalent amongst males, we noted that there's a sharper increase among the female population at about 35%. Then when we look at age and racial distribution, young adults and Black non-Hispanics are disproportionately affected by early syphilis. Taking a closer look at the increase amongst females, there's a continuous increase among females of childbearing ages. From 2013 to 2018, there was over a 90% increase, which brings us to the concern of congenital syphilis. Congenital syphilis is a transmission of syphilis from a pregnant person to their newborn. If left untreated, it can lead to stillbirths, miscarriages, and clinical manifestations such as bone deformities, blindness, and deafness. 2019 marked the 3rd consecutive year of increases, with a case count of 10 cases in 2019. The map draws attention to the observation that where rates of primary and secondary syphilis are high among females of childbearing age, cases of congenital syphilis tend to be present as well. Similar to New York State, the nation is experiencing increases in syphilis diagnoses and congenital syphilis cases. Recently, an MMWR looked at meth and heroin use, injection drug use, and sex with a person who injects drugs in the United States amongst women, men who have sex with women, so MSW, and MSM, men who have sex with men. And there are 3 main takeaways. First, there was a notation that primary and secondary syphilis rate among women increased by 155% from 2013 to 2017. Second, the number of individuals diagnosed with primary and secondary syphilis and reported meth use, injection drug use, heroin, or sex with a person who injects drugs more than doubled from 2013 to 2017. Lastly, there's a need for collaboration between STD control programs and substance use disorder services and partners. So this MMWR prompted this evaluation to see if the same findings hold true for New York State. We wanted to identify whether the drug use-related behaviors are associated with the sharp increase of early syphilis among females in New York State. To conduct this evaluation, we utilized 2 sources of STI surveillance data and did a test of association. We used New York State's STI registry and partner services investigation data. Then we calculated the proportion of engagement in DUBs from 2013 to 2018 among men who have sex with men who have sex with women, and females. Then we took a closer look at the female population, restricted the data to only 2018, ran a chi-square test to identify any associations between the clinical and sociodemographic variables and the drug use-related behaviors. After those series of steps, the data produced a few interesting findings. We're going to take a look at DUB engagement and associations with region, race and ethnicity, and source of case report. So first, we're going to take a look at DUB engagement. When calculating the drug use-related behaviors, we looked at any person who reported yes to the 4 behaviors. The table here highlights only females because we know there's sharper increase with the drug use-related behaviors. And also, we wanted to look at this with regards to the sharp increases we're seeing in the early syphilis cases among females that I noted earlier. Compared to 2017, in 2018, there were 5 times as many females using heroin, 6 times as many females injecting drugs, 7 times as many females having sex with a person who injects drugs, and then and also 4 times as many females exchanging sex for drugs and money. Then for analysis purposes, we created a new variable representative of females who engage in at least 1 DUB, which is highlighted in the slide. So from 2013 to 2018, the percentage of females reporting a drug use-related behavior tripled. In 2013, 8.6% of females engaged in a DUB, and then in 2018, it increased to over 30%. To further describe and identify these females, we looked at socio and clinical demographic variables that we collect from our STI registry and partner service investigation data. And then we ran a chi-square test to identify any associations with the DUBs. We restricted the data to only 2018 due to the sample size being larger. The chi-square analysis shows significant associations between the drug use behaviors and race. A high proportion of females with syphilis reporting a DUB were white non-Hispanic individuals. We would like to make a note that a high proportion was seen among the Asians and Native American population. However, the sample size were small. This is important to note when we think about targeted screening initiative with regards to race and ethnic groups. The chi-square test also shows significant associations with regional differences. New York State is broken down into several regions. Rochester region, shown as a darker blue shaded area, had the highest proportion of females who were diagnosed with early syphilis and reported yes to drug use related behavior. One thing we would like to note is Monroe County of the Rochester region. So during this time period in 2018, Monroe County implemented a targeted screening initiative within their jails and also had a targeted community outreach program for populations engaged in drug use related behaviors. So this may have attributed to the high proportion that we see in the Rochester region. Lastly, another interesting finding was a source of the reported case. About a third of the diagnoses among females who were diagnosed with early syphilis and engaged in a drug use-related behavior were diagnosed outside of the traditional health facilities such as clinics, hospitals, public and private doctors. So about 9% of the diagnoses were made at rehabilitation facilities, and 24% of the females were diagnosed in correctional facilities. This implies that there's a need to meet populations where they are to provide screening, treatment, and referral services. By doing this, it will help us identify syphilis among those who either lack physical access or who lack access due to fear, stigma, and misinformation. So now after looking at this data, what does this mean and what does this prompt the Office of Sexual Health and Epidemiology to do next? So similar to the MMWR, in New York State, there's a clear need to align our efforts in STI prevention and harm reduction with the drug user health programs, and then target efforts to specific regions and counties, race and ethnicities, and also facilities. There should be an increase in screening amongst populations in areas where drug use-related behaviors are highly prevalent, and also an increase of screening within the jails. This evaluation was just a spark to further analyses and evaluations. We would like to further identify and describe these females and also analyze the drug use-related behaviors among those diagnosed with chlamydia and gonorrhea to see if we see similar patterns. We also want to compare the outcomes of pregnant females with early syphilis and a drug use-related behavior and pregnant females without a drug use-related behavior in connection to congenital syphilis. And then we would like to collaborate and share findings with key stakeholders, specifically the drug user health programs. So once again, thank you for attending this presentation. We appreciate it. And also thank you to Sri, Wilson, and Rachel for making this evaluation possible. If you guys have any questions or comments, please feel free to email us at stdc@health.ny.gov. Thank you.